Sebastian.
All right. Good morning, everyone. It's my pleasure to welcome you to our second part of the ERC ResearchNet sessions. Today, I will host this together with Bernd Böttiger and Gavin Perkins, who will introduce themselves shortly. My name is Sebastian Schnaubert. I'm working in emergency medicine at the Medical University of Vienna in Austria, and I'm also affiliated with ILCOR and ERC guideline process. And we will have many very interesting presentations, talks today about projects that are going on inside ERC ResearchNet. And before we do that, I'd like to ask Bernd and Gavin to introduce themselves. And after that, Bernd will, together with Gavin, give a few overview words about ERC ResearchNet, and then we will start with our presentations. Bernd.
Okay, thank you very much, Sebastian. I will briefly introduce myself. I'm Bernd Böttiger. I'm from the Department of Anesthesiology and Intensive Care Medicine at the University Hospital in Cologne. In Germany, I'm sharing the ERC ResearchNet for 8 years now. Unfortunately, this is the time that is allowed by the ERC statutes. So I'm happy to give this position over to Gavin Perkins now. And with regard to ERC ResearchNet, I would like to make some very brief introduction words. We started in 2013 in Krakow in Poland during the resuscitation congress from the ERC there. Initially, we have been 18 members, and the goal was to further develop research under the umbrella of the European Resuscitation Council and to connect many researchers in Europe in this network and under this umbrella. And after 7 or maybe 7.5 years from then, we have more than 200 members now. I have a conflict of interests, but I would say this is just a great success story. In the meantime, we have 57 scientific publications in international journals, including The Lancet and many high-ranked journals with more than 250 impact factors. Overall, we have developed together the ERC ResearchNet Summer School since 2017, when we were starting this in Freiburg in Germany during our ERC Congress. We were able to get funding from the European Union and from the European Commission, with made us able to participate in, for example, in the ESCAPE-Net and in the PARC and COST consortium. So we are really a great network in the meantime with high visibility. And this is ERC research. And this was able because we really were able to collaborate and we had high levels of motivation. We had many young people within this network. And I'm very thankful to all. And I'm also very happy that Gavin Perkins is now taking over, and I'm more than happy to support ERC ResearchNet also by myself in the future. And with this, I would like to give over to Gavin.
So thank you very much, Bernd, both for that kind introduction, but also how much you have given and how far you have mentored and grown the ERC ResearchNet. I think as we all look back over the course of the last 8 years, the network really has gone from strength to strength. But one of the key things as your new incoming Director of Science for the European Resuscitation Council is to reach out to the network to find out what are the important priorities for you. What would you like us to do more of? What would you like to do less of? And what would better look like when we reflect back in 5 years' time and look at the growth and success of the network? I think some key things I've taken away from the network have been collaboration, friendship, expertise, but I really want to hear about those ideas from all of you. Over the course of this 90-minute session, we've got 3 polls, one of which is showing at the moment, and it's great to see that 46 people have responded to that poll. There will be 2 further questions coming out during the meeting, and it would be great to get people's views as the conference progresses. I will come back to the ERC ResearchNet over the coming months to seek your views, your ideas about what makes a great network and an even better network. And so without further ado, I'm going to wrap up at this point and hand back to Sebastian to start off today's session. Thank you.
Thank you very much, Bernd and Gavin. Yeah, there's nothing more to say, but a short reminder, if you have any questions about the presentations that are going to start now, please ask them at Slido, in our Slido app or the web page, and we will try to answer them after the presentations. So now our first presentation will be on the project involving school children or teaching school children, given by Naomi Nakavaga. And Naomi, the stage is yours.
I'd like to thank our great mentor, Professor Bennett, and also Dr. Gavin and Sebastian for the opportunity to discuss our work with the low-cost handmade mannequins. I have no commercial conflict of interest. Please, the next one. Bystanders' performance in CPR is crucial to improve victims' survival and quality of life after sudden cardiac arrest, as emergency medical services take several minutes to arrive. CPR training requires personal resources, efforts, and equipment, as well as they are time-consuming. Kids Save Lives in the World Restart Heart and the UCOR have recommended CPR training school children from the age of 12 years or even earlier. Children and adolescents are recognized as possible multipliers to educate their citizens' peers. Although UCOR has recommended 2 hours for CPR training, a shorter period of 40 minutes may be another strategy associated with good results. Additionally, the low fidelity, low cost mannequins have emerged as useful alternatives to intermediate fidelity mannequins in CPR training, particularly in developing countries or very populated areas. The aim of this study was to analyze a shorter program with low-cost handmade mannequins with recycled materials and a longer program with the 2 hours with intermediate fidelity mannequins. Next one, please. Our study was an observational prospective study that was approved by the local ethical committee, and it was performed between February 2019 to January 2020. And the participants were children, adolescents, and adults of public school communities, school members of the 4 regions of São Paulo that has around 16 million people. The inclusion criteria was people with no prior CPR training, aged more or equal to 6 years old, after agreement with informed written consent. Next, please. The 2 programs were a shorter program with low-cost handmade mannequins with recycled materials created by Spielman and collaborators, a longer program with the 2 hours with intermediate fidelity mannequins. Next, please. The 2 programs using Kids Save Lives Brazil with intermediate feedback included 1,977 learners aged from 6 years to 7, 8 years old in the school communities. There were differences between groups in age. Both had more female. However, sex was not an independent factor for skill achievements. Next, please. Performance in between younger and older was different for individual skills. However, the completion rate for all skills components in the shorter and low cost with handmade mannequins program was equal or higher than 89% throughout. Our study showed that the success rate, please, the next one, of the overall CPR skills are high. However, for implementing specific skills, you should consider, please, the next, age, the period of training, the type of mannequin, Our study showed increased success rates with age in developing the following skills: in assessing local safety and all skills for effective chest compression, probably because it was associated with the body mass index. Next. There were also success rates with the longer program in developing the following skills: checking local safety, checking responsiveness, calling for help, assessing the victim's respiration, and chest release. Next. The last one, probably because people need more time to understand and to simulate the situation and try to get more experience from the simulation. Next, please. There was some decrease in success rate with the low-cost program in developing the depth compression because the absence of a system to measure depth in the plastic bottles in the low-fidelity mannequins is one problem. And the next one is the plastic bottles are not feasible to record this, the depth of the compression. The number of learners in each program was different between them. However, both programs had participants from school from 4 regions of São Paulo city area. The prevalence of female learners was higher in both groups. These findings may be associated with the possibility that female students may be more motivated to participate in CPR trainings, as pointed out by others. However, in our study, sex was not associated with CPR skills results. We did not perform any follow-up on knowledge and skills retention in participants of each group and did not assess the impact of such programs in health systems because they were not the focus of this study. However, we could identify tasks that young children don't perform well and indicated that more intensive training is needed in these areas. And for finally, we provided relevant information on the high efficacy of a shorter and low-cost program with the handmade mannequins to improve individual CPR training, as well as being feasible for massive CPR trainings in developing countries or in very populated areas. Next. We concluded that our study showed that a shorter and cheaper learning program can be useful in CPR training at school communities with the completion rate equal or higher than 89% throughout for all CPR skills components. I show you here how to make the handmade low-cost mannequin with recycled materials. It costs very few cents. Thank you very much for your attention.
Thank you very much, Naomi. I think we have time for one very short question. There was a question if your research is already published, if people can find your publication online.
Yes, it is available online. It was published in American Journal of Cardiology.
All right, so maybe
we still continue with this research with low-cost mannequins. And if someone wants to join us, it will be very welcome. Thank you.
Perfect, thank you. I think someone already posted the link to the publication at Slido. Thank you very much.
Okay, thanks again, Naomi. We are moving forward, and I think your publication is also maybe open access, so it's at least accessible through all the networks, and it's a great thing to have these low-cost mannequins. We proceed to the next speaker, and the next speaker is Jean-Louis Clint. and he is giving us a presentation on innovation in BLS AED training in schools and beyond, the AED training box. So Jean-Louis, please proceed.
Good morning. I'd like to share my screen. Just a moment. I don't know if you can see my screen now.
Not yet. And now
Yes.
we can see it.
Okay.
Thank you.
I'm Clint Jean-Louis. I'm an emergency physician. I work in pre-hospital in an ambulance, and I'm also a founding partner of a not-for-profit organization, which is the ABC Saves Lives Association. And we started about 10 years ago. Given, just a second, I've lost. Sorry about that. Exactly. I have no conflict of interest. If you have any conflict of interest, I'm not going to be to get rich by doing this. I'll get rich as a person, and I hope many lives get saved. That's the only conflict of interest I have. We started the school program 10 years ago. We train teachers to become confident and competent BLS providers, and once they feel confident, we offer them the possibility to teach within the school community by giving them mannequins and by also giving them all the didactic material for them in English, in Spanish, and in Basque language. In 2014, the province approved of it becoming mandatory in our province, and that was in primary school, and also in the second and fourth year of secondary school. We've trained now it's almost getting 2,000 teachers so far, and our target teacher was the physical education teachers. We believe that ideally, they're in a good context to teach CPR, but we found that also the more teachers who learn CPR, who learn BLS, the stronger the school community has, the stronger the program becomes. By 2021, hopefully this year, 100% of our schools will have at least 5 mannequins each, and larger schools have more mannequins, but they have a rental scheme which is for free, and they can get mannequins whenever they want. It's been suspended due to the COVID, but usually they have, all schools have 100% access to mannequins. So far, except for 2020, that's why I was thinking about, should we forget about 2020 when all training in schools was stopped? And but we found there's an opportunity, and that's why I'm going to present the AED training box, where we think we can restart and help them to start training again, within the school community. Well, what happened is that once teachers learned that an AED trainer is not something very complex to use, they started asking us for AED trainers. And many of you know that an AED trainer, which is of an acceptable quality, is quite expensive. We buy mannequins, but we wouldn't be able to supply 300 schools with AED trainers. So we took up the challenge to invent one, and I don't know, we might not have time, but if anyone can go as a phone and open a browser, he can go to the aedtrainingbox.com, and I could actually show them how it works. I could also, I don't think we'll have time, but I'll explain how it works anyway, just quickly. The next slide. Okay, I don't know if I can show you this video. Let's see. Now, what it consists of is a simple carton box, which any student or any person can construct within 10 minutes. So the person gets an envelope with what we've done is we've used all the elements of the product, so we don't throw anything away. So even the envelope shows you where you can place your AED pads. And we also have a puzzle at the back of the envelope. You see we have some leaflets with CPR, a diploma. We designed this box and the app which goes into any mobile phone with teachers, and that really helped us to get the insight on what they actually need. So the app is not only an AED trainer, so to speak, it's also a guide to teach. We have different scenarios where, for example, they learn how to manage a patient who is alive but has a heart problem, what to do, a patient who's does not respond, they do the safety position and cardiac arrest, and also and then you have the simulator. So this is just basically how they construct the box, which is, as I say, in 5 minutes. In 10 minutes, under 10 minutes. I don't know, I'll stop this and continue. Okay, so this is the instructor mode of the app, where a teacher can program a training session, and then in another phone which is placed in the box, the teacher has access or through a PC or through a tablet or through the app, and a phone is placed in the box. And that's on the right side. You can see the student can watch a video, as you see on the left. He can also, then if he goes into the AD trainer mode, then the phone, it works as if it's an AD simulator. In next month we'll hopefully get our English version out, and yeah, I was going to end here. This product won some awards last year and the year before. So last year, 2020, hasn't been a very bad year for us. So we couldn't do a lot of training in schools. We've tried to create new tools for them, and there's no time now to do it, but I could actually program this trainer from here in Spain. And if you opened it in your phone at home, you'll be able to have the AD. I'll be able to send you a scenario, and you'll be able to see the simulator yourself. In February, we had a course, a trial approved, and it was suspended due to a surge of COVID in Spain. So it's going to be scheduled this April and May. And hopefully at the end of this year, we'll be able to publish something on this product. Thank you very much.
Excellent. Cordial congratulations, Jean-Louis. This is a great idea, and you have already received some awards for this. And thank you very much for sharing the website and your email address for all those who are interested in getting more information and to learn from you. There's no question in Slido for you now, so maybe we will have some further questions at the end. For this very moment, I will give the microphone now to Gavin for the next speaker.
Thank you.
Thank you very much, Bernd. And I think I've seen some questions coming through on Slido. So if you were able to look at that and respond to people, that would be great. So it's my pleasure to introduce our next topic, which is results from the ENSURE, PEACE and COVID-19 studies that's going to be delivered by Simone. Thank you.
Good morning, everybody. Now I'm sharing the screen. Okay, my name is Simone Savastano, and I'm an invasive cardiac electrophysiologist at the Fondazione RCCS Policlinico San Matteo in Pavia, in Italy. It's a great pleasure for me to be here online speaking about the ENSURE study, the PEACE study, and our insights about the relation between OCA and COVID-19. I have no conflict of interest. So moving from the ENSURE study, it's a multi-center European study about the role of late defibrillation And the primary endpoint was to estimate the rate of AED used by lay rescue by the first responder or before the EMS arrival. And these are the participating country, and we have just closed the enrollment with 19 countries with successful field questionnaire. We now have the analysis scheduled by mid-April and the first draft of the manuscript planning in mid-May. So unfortunately today I have no results of this study because the enrollment has been closed very, very soon. But on the contrary, I have a very interesting result of the PEACE study. The PEACE study is a multi-center retrospective international study about the timing of ECG acquisition after ROSC. Pavia was the coordinating center, and Vienna and Lugano in Switzerland were participating center. So we analyzed every post-ROSC ECG, and it was categorized in positive or negative for STEMI. And then we looked for a correspondence with the coronary angiography. So we have analyzed more than 500 ECG, and the results are very impressive. So as you can see here, the main finding of the study was that if the post-ROSC ECG was acquired within 7 minutes after ROSC, we had a 20% of false positive. That is to say, a 20% of patients showing a STEMI to the ECG, but without the need of a coronary intervention. And I think this is a very, very important observation because from the ECG post-ROSC may depend on some decision, some clinical decision, such as the admission of the patient. Then we published some papers about the relation between OCA and COVID. As you know, the first pandemic wave started in February 2020 in the province of Lodi, and at those time, our cardiac arrest registry was covering the province of Pavia, Lodi, Cremona, and Mantua. In our very first paper, we followed the first 30 days of the pandemic, and we show an increase of cardiac arrest. We were the first demonstrating an increase of cardiac arrest of 58%. But when considering each province, we saw a dramatic increase of cardiac arrest in the province of Lodi and Cremona, that was the most hit provinces in our territory. Concerning the characteristic of cardiac arrest in 2020 were more medical etiology, more home located, and unwitnessed. When we reanalyzed every case, and we saw that the 4% of cases of cardiac arrest in 2020 had suspicious or undefined diagnosis of COVID-19. And when considering only the excess of OCA in 2020, the 12% of cases have had a suspected symptom or a defined diagnosis of COVID-19. Then we observed the first 60 days of the first wave pandemic, and we saw a strongly statistically significant correlation between the cumulative incidence of COVID-19 per 100,000 inhabitants and the difference in cumulative incidence of OCA. And this was statistically significant in the whole territory and in each province. Finally, we addressed the treatment, the attitude of treatment out of hospital cardiac arrest during the COVID-19 era. And what we saw was that the attitude in performing ALS was lower, but when ALS was performed, the results were similar to the previous year. And if you can see here, the suspected of confirmed COVID-19 diagnosis was not a predictor of ALS treatment. So the rescuer the rescuers were not afraid of infection. And as you can see here at the multivariable logistic regression model, ALS was performed less than 2019 because an increased number of non-shockable rhythm, unwitnessed event, and no bystander CPR. Finally, in a very recent letter published under solicitation, we demonstrate that the correlation between out-of-hospital cardiac arrest and COVID-19 disease was not only present in the ascending phase of the pandemic wave, but also in the descending wave of the pandemic wave. So I thank you very much for your kind attention.
So thank you very much. That was a fascinating presentation. Thank you for sharing your insights in COVID. If you were to look back at events over the course of the last 12 months, what would you say would be the single most important intervention that we could have done to save more lives from cardiac arrest?
I really think that the more important suggestion were the guidelines in COVID-19, because cardiopulmonary resuscitation is a crucial, a pivotal role for life saving, and the having released some guidelines really focused on cardiac arrest treatment in the COVID-19 era was, from my perspective, very, very important to help the rescuer to resuscitate the patient.
Okay, thank you. I think we're out of time on this one. I'd like to thank everybody who's responded to the polls so far. During the next talk, I'm going to transition on to the next poll. So if people want to respond to what would you like to see more of the ERC Research Net do, please do log into that poll as we'll be moving to the next question shortly. I'm going to hand back now to my co-chair, Sebastian, who's going to introduce the next speaker.
Thank you, Simone, for this very interesting data. Next presentation will be Stefan Birkmeyer, who will give us some insights on the device and also some preliminary data, I believe. So, Stefan, please.
Okay, thanks for the inviting words. I just want to share my screen. Okay, so sorry, I have a problem sharing my screen. Lars, could you show my slides, please? Thanks a lot. Okay, my name is Stefan Birkmeyer. Today I want to talk about a smartphone compression feedback device for CPR. So could you please show the slides in presenter mode, Lars?
Lars, we cannot see the slides anymore. Now they are coming back, and please go into the presentation mode if possible.
Thanks,
Very good.
Lars.
Excellent.
Okay. Next slide, please, Lars. I don't have any conflict of interest, and the study was supported by the Danish Market Development Fund. So the system I want to talk about is called CorePatch. On the left side, you see the system, and also here in my hand, it's very handy. And on the right side, you see the via Bluetooth connected feedback screen on the smartphone, and 2 green bars and a red moving one. So please, can you start the video? It's here. Yes. The green bars are the upper and lower limit, and the red bar is the live position of the compressions. For example, if a participant is compressing too gentle, please play again the video. The green bar turns yellow and the word deeper occurs, and a voice encouraged to press also deeper. So all in all, it's a simple and user-friendly app. Next slide, please. The purpose of the study was to find out if chest compressions performed by nurses after a BLS course are more within the guidelines when using core patch than without using the system. Next one, please. So just a few words on the materials and methods. It's an ongoing multi-center study, and due to COVID-19 restrictions, we could only start with these 3 centers. The study is done with nurses during a BLS course, and the scenario was a 3 minutes thorax compression without any ventilations. Okay, so just go to the next slide, please. Here you see a scheme. So the study is built around the BLS course. First of all, a pre-test without any feedback. And after the BLS course, it's done a post-test. And for the post-test, please, next slide. The participants are divided into 2 groups, one with the feedback, the other without feedback. And because we also wanted to check on the training effect, we decided to do a follow-up after 3 and 6 months. Next slide, please. Yes, it's the post-test 2 and 3. Next slide, please. So we could enroll 69 participants so far, and the overall key message is that the performance with the feedback device was more within the guidelines than without. And for detailed results, I want to show you the following slide. It's on the left side, you see the intervention group, and on the right side, the control group. So at first appearance, there seems to be no really difference. And I say that's partially right, because when you have a look at the mean values for depth, frequency, and recoil, there is not much of a difference. But for us, the crucial and essential distinction between the groups is the percentage of the correct compressions according to the guidelines. So for example, the intervention group improved the proportion from 40 to 60% according to the depth, whereas the control group kept the initial level from 40 to 40%. And these results can be found more or less in all measured parameters, depth, frequency, and recoil. To explain it more graphically, I want to show you the next slide, please. It's a box plot of the depth in minute 1, 2, and 3. And the x-axis are the different tests. So 0 mean is the pre-test for the intervention group. 1 means it's a post-test for the intervention group, and 4 and 5 is the control group. So clearly you can see that the depth is going to be smaller and smaller over time without a feedback, and the spread is huge. So in comparison, let's have a look at the post-test with feedback. It's number 1. The depth remains the same over time, and the spread is way smaller. In contrast, the control group improved just a little bit after the BLS course. Next slide, please. And same picture for the frequency. Okay. Next slide, please. For sure, it's an ongoing study, and therefore there are just preliminary results and the missing post-test 2 and 3. Next slide, please. And there have been published quite a few studies about feedback devices in the last years with varying results. And for further discussions, I want to come up with this study, for example. Next slide, please. It compared 3 devices, and the conclusion was quite disappointing. So no real benefit from a feedback device. And we believe that the usability of the system and how the feedback is given are crucial for the performance of the participants. And therefore, we're excited to do further studies and to evaluate the usability of some feedback devices. Next slide, please. So thank you very much.
Thank you, Stefan, for this very interesting insights. I believe there are no questions so far on Slido. I'd be interested in if you're planning on also including or doing another study on non-healthcare related proband people, testing it on lay people.
Yes, we're planning it in Denmark, but it's in the planning, so not started yet, but we're planning it, yes.
All right, thank you very much. If there are no further questions, I'd like to hand over to Bernd to introduce our next speaker.
Yeah, thank you very much, Sebastian, and thank you very much for all the previous speakers that you have answered so many questions in Slido. That's a good way to handle all these issues. And now we are jumping to Russia, and it's really a great pleasure and a great honor for me to introduce a colleague who is extremely active over many years, together with Professor Moros and others in Russia. It is Artem Kozovlev. He is a clinical researcher, an intensive care specialist at the Negovsky Scientific Research Institute of General Reanimatology of the Russian Academy of Medical Sciences in Russia. So Artem, the stage is yours, please.
Thank you so much. I'm honored to be invited to this Congress, and the title of my presentation was preliminary, put in the program as very wide, recent studies in resuscitation, but definitely I would like to focus on one topic, which is team and leadership training, because recently we have run some research on it, which was used in the current guidelines, which is quite exciting for the whole research group. So I have no conflict of interest to be disclosed, and really advanced life support is a teamwork. It is reflected in the guidelines. We always work in teams: chest compression, defibrillation, airways, team leader, registrator in some teams. And a big question is how to teach these team and leadership skills. And the question, which is even bigger, even more important, is if things we teach in simulation centers during the courses, during the advanced life support courses, if they are translated into the real life situations. And team and leadership is a very complex skill. There are some team skills, leadership skills, situation awareness, communication skills, briefing and debriefing. So it's a very complex issue. So, and we run a systematic review, which was recently published in Resuscitation, which is directly called The Effect of Team and Leadership Training of Advanced Life Support Providers on Patient Outcomes. So we analyzed some data, and really just 12 studies, 7 randomized and 5 non-randomized, were included, which were added to 19 studies from 2015 and analyzed as a block using the GRADE methodology. The big limitation of this study was definitely, as we expected, that the studies were very heterogeneous. So there were trauma studies, advanced life support studies in adults and in neonates and in pediatrics. That's what we had. And unfortunately, we had no studies, no randomized studies addressing patient survival. Just 3 observational studies which proved and reported improved patient survival. And studies reporting skill performance in actual resuscitations. Just 1 randomized study with no effect on CPR quality during actual resuscitation in patients. And 4 quite heterogeneous observational studies. In all the other studies, lots of them, but still there are just some skills, teamwork, leadership, and in majority of studies, you cannot split team training from leadership training, so it's quite complicated to analyze it. But still our conclusion was that very low certainty evidence. We have evidence. It is a very low certainty for improved patient outcomes if team and leadership training is included as a part of a structured advanced life support course. And this evidence does support a recommendation that team and leadership training should be included as a part of advanced life support courses for healthcare providers. And this systematic review was translated into the recommendation of the educational chapter of the ERC guidelines for this chapter of it related to healthcare professionals at different levels of response and duty, that specific team and leadership training is suggested to be included as a part of ALS training for healthcare providers. It's a weak recommendation with very low certainty of evidence. Thank you so much.
Thank you very much, Artem, for this great work and great presentation, and also for the information that this work already made it into our current guidelines that have been published the night before last night.
Thank you.
So we have some few minutes left. We have 4 minutes and 30 right now. If there are any questions, I cannot see any questions to you related to your presentation in Slido, but maybe I take the opportunity and ask you to say just a few words on the Negovsky Scientific Research Institute, so that everyone knows that institute in the future. And maybe you should tell us something, if you like, about your future plans of research in your lab and in connection with the ERC Research Net, if you like.
Oh, thank you so much for this opportunity. Really, the Negovsky Research Institute now is a development of that very first Negovsky Research Lab. And now we have a very wide field of research in intensive care medicine, mainly basic research translated into clinical practice. And we are very excited to have this interaction with European Resuscitation Council, because we have some experimental models of cardiac arrest and related to cardiac arrest and post-resuscitation period. So maybe interaction in this scientific field will be quite exciting for us.
Okay, thank you very much. Are there any further questions from the people in this panel to Artem? This is obviously not the case, and I again cannot see any.
Tino has a question, Bernd.
Okay, Tino, please.
Artem, are you going to do a study now on leadership in clinical practice? Because you mentioned we don't have randomized controlled trials on leadership, performance, and patient outcomes. So is this a topic you are going to follow up?
I have this idea, but it's so difficult. I have this idea, thank you. Yes.
Okay, already some good suggestions for further collaboration within the ERC Research Net. Thank you very much, Tino. Any further questions? I cannot see any. So Artem, thank you very much. Good luck for your further research and best wishes to Professor Moros. And I give the microphone over to Gavin.
Thank you, Bernd, and thank you, Artem. So it's my pleasure to introduce our next speaker, Yasmin Talab, who's going to talk to us about mRNA as a novel biomarker for prognostication after cardiac arrest. Thank you.
Okay, hello everyone. Greetings from Germany, Heidelberg as my host country, and from Egypt as my home country. I'm gonna share my screen, just give me 1 second. Okay, I hope it's clear now.
Yes, we can see it very clear.
Okay, I'm gonna talk about the prognostication for the neurological outcome after cardiac arrest. Particularly, I'm gonna shed the light on the microRNA as a promising biomarkers in this field. The current research project is a collaborative work between the University of Heidelberg and the European Molecular Biology Lab. It's ethically approved in September 2019, so we are still in the very beginning steps of such a research, which is quite different from what's presented already today and yesterday also. The first questions popped up in mind usually in the prognostication domain is why we prognosticate. We prognosticate actually because even with successful resuscitation and return of spontaneous circulation, still the post-cardiac arrest syndrome contributes to unfavorable neurological and cardiac outcomes, and thus compromises hypoxic brain injuries, the heart dysfunctions, systemic ischemic reperfusion responses, and of course, precipitating pathology in different organs. So I would like to show up here our research design that from this point of the post-cardiac arrest syndrome, we thought that the ability or enabling physician and clinician to predict the outcome at early stage after cardiac arrest would enable them to tailor the patient plan for the treatment. They could also help clinician and physician to triage the decision on how to continue the treatment with the patient, remodel the treatment, or maybe withdraw the treatment completely if there is a bad prognosis. And in this context, there is a lot of biomarkers research which publish, unfortunately, controversial and conflicting results in the field. There is a long list of biomarkers that is secreted, for example, from the brain, from the heart, and finally, rush into the circulation or excreted already inside the peripheral circulation. We have a previous publication, which was also presented as a poster presentation in ERC Congress 2018, that discuss also this panel of biomarkers for the neurological outcome and how these levels, the measuring levels, could associated with a bad and good outcome. So why these conflicting results actually, or why these conflicts arise from? It's because of many confounders related to the study design, the time of treatment, the time of sampling, laboratory evaluation, the endpoint of treatment. But the main conflict is when these biomarkers secreted inside the brain, they rush into the circulation, and then we measure these biomarkers inside the circulation. But the real fact is the rushing of these biomarkers inside the brain is different in the filtration rate to the circulation. So there is many barriers that makes these levels are different from one person to another. And even with only 2 available biomarkers that are industrially calibrated as an assay, available assay, the neuron-specific enolases and protein S100B, which is available in some trauma centers, they are enriched inside the brain, but they are not specific actually to the brain injury or cardiac arrest. The other problem is the stability of these biomarkers that is used in the biofluid, we mean in the CSF and the blood. And here comes the point, the state of art. Clinicians don't want actually to read these thousands of studies that every day published. They need something in hand like a blood test that could help them to know exactly the prognosis and the prediction of the outcome at early stage after cardiac arrest to decide how to continue the treatment with their patient. And they also need a kind of biomarkers which is stable, specific, easily detected in minor quantities, and to be stable in the peripheral biofluids. So these criteria and this behavior is typically applied to the microRNA molecules. By the way, microRNA molecules is the technique that is used for some vaccination and COVID disease nowadays. So we started our research project, the autopsy research or the postmortem research. We used the postmortem human tissues together with the blood and CSF after some control for the postmortal interval, the pH measurement, and the tissue fixation. And we started our chromatin-based epigenome assay to test these microRNAs. Our expected result, which is not yet ready actually, is to have this novel, minimally invasive, blood-based test that could be used in the clinical routine. These are some of the preliminary unpublished results, which we succeeded to optimize the methodology of how to use the tissues post-mortally after some control. Thank you so much for listening, and I hope it was catching your interest. Thank you.
So thank you very much for that that nice presentation. I'm just having a quick look in the Slido. A moment or two ago, there weren't questions specifically for you. So while people are perhaps thinking about those questions, in terms of the timing of sampling for a biomarker, a two-part question, both when do you think is the optimal timing from a clinical practice point of view, and at what time would your mRNA biomarker best be sampled?
Actually, with control, because using the postmortem tissues is very challenging, actually, because no one can control exactly the postmortem interval. But the best is the postmortem interval between 4 hours to 12 hours with control of the pH measurement, the rapidity of death. This is one point to be analyzed as well, and how to fix the tissue for further microanalysis and epigenomic analysis. So these are the 3 factors that could be considered when using this. This is the microRNA, and the microRNA, the advantage is they are very stable after death, actually. So they could be used even after 12 hours, or of course after before these 12 hours.
Okay, thank you. I'm going to open up to the panel while I check the Slido again. Did anyone in the panel have any questions?
There was one question to you, Yasmin, because several people are interested in a link to your presentation. So if you have a link for your presentation, it would be great if you can put it into the chat and or into Slido.
Okay, yeah, sure.
Thank you very much.
Yeah, you're welcome.
Many thanks. Okay, well, I think we're on time to move to our final presentation. So I shall pass back to my co-chair, Sebastian, to introduce the next speaker. Thank you.
All right, thank you. As you said, this will be our last presentation on a specific topic before we maybe discuss general topics together. And this presentation will be given by Tino Greif and Anja Lewis, and it will be on Reboa and its use in non-traumatic cardiac arrest. Very interesting and novel topic. So please, Anja and Tino, proceed.
So my job is only to introduce Anja, who is the first author of a paper, and she's the lead in this very interesting project on a new approach which might improve the outcome in cardiac arrest. And with any further ado, I would like that Anja presents the study and what are the future projects. Anja.
Hi everyone from my side, and thank you, Tino, for the introduction, and especially thank you for giving me this opportunity to talk to our colleagues from the ERC net about the idea of resuscitative endovascular balloon occlusion of the aorta in non-traumatic cardiac arrest. As you mentioned, we did a study together at the Inselspital, which is the University Hospital of Bern in Switzerland. I'd like to thank also the other contributors. This was a study involving several departments and wouldn't have been possible without their collaboration. I don't have any personal conflicts of interest. The medical company producing the ER Reboa catheters sponsored 3 of the 15 catheters we needed for our study. But before getting into our results, let me just quickly recap what Reboa is about. It's the acronym for resuscitative endovascular balloon occlusion of the aorta, and it's a technique primarily known from trauma resuscitation. If you imagine a patient injured with a vessel injury somewhere in the pelvic region, and your patient is in hemorrhagic shock, you're far away from any operation theater, then you could put in your catheter with the balloon on its tip, inflate the balloon, stop the blood from moving to the injured side and being lost from your patient's circulation. But the hemodynamic effects of Riboa are much more than just to stop your patient from bleeding out. If you occlude the aorta here, taking out half of the vasculatory bed of your patient, then the remaining circulatory volume in the upper part of the body will increase central aortic blood pressure, therefore also increase cerebral and coronary blood perfusion pressure, and subsequently blood flow to heart and brain are increased. Now, to benefit from an enhanced perfusion of vital organs, your patient doesn't necessarily have to be exsanguinating, but animal models showed that when Riboa was performed in cardiac arrest in animals under CPR, exactly these effects, the same effects, could be seen. As you know, CPR, the main goal of CPR is to maintain coronary and cerebral blood supply, but when we are doing CPR, even when we're doing it at our best, we are far away from a luxury perfusion. So if animals profit from Riboa or benefit from Riboa during cardiac arrest, maybe humans could too. And this is exactly what we'd like to investigate and actually have started investigating already. This is a study published in last year in Resuscitation. It was a single center in-hospital observational trial where we included 15 patients suffering refractory out-of-hospital cardiac arrest. They were transported to our hospital after unsuccessful ALS at the scene, and we performed Riboa as an ultima ratio in these patients. It was a feasibility study, so our primary outcome was a successful placement of the catheter and subsequently occlusion of the aorta. And as you can see here in our results, we were successful in 9 of the 15 patients with a median time to inflation of the balloon of 9.5 minutes. So we concluded from our study that ultrasound-guided Riboa in patients undergoing CPR is not easy, but it's feasible, at least in the controlled and familiar environment of our resuscitation bay. Of course, to be of any impact, such an intervention will have to be applied much earlier in the course of treatment of these patients than we did in our study. So the next step will be to take the protocol to the preclinical scene. And this is a study we are about to start just now, where we'll apply the same protocol in 15 patients at the scene of their arrest. Our ethics committee required this step with another small number of patients, and checking feasibility of this protocol. As you can imagine, the ethics committee had a rather hard time when discussing our studies. But of course, what is really interesting is the outcome after cardiac arrest. What we will measure already will be whether Riboa has an effect on central blood pressure measured at the tip of the catheter I showed you, and tidal CO2 and cerebral oxygenation. But after all, what will be interesting is short and long-term outcome and neurological outcome after cardiac arrest, and if Riboa has any effect on this. And our vision is to do a multi-center randomized controlled trial where we are investigating exactly that. So I thank you for your attention. If you have any questions or are interested in participating for our vision of this study, please don't hesitate to contact me. You can see my email address down here. And now I'm open for questions.
So I think I'll step in. Sebastian has put a message in the chat that he's had to leave the session in order to go and resuscitate a patient in cardiac arrest. So we wish him well with those endeavours. So thank you very much for that nice presentation. I guess the question, because I haven't seen any in Slido as yet, is, you know, what do you consider the next steps in terms of you know, translating what is a good concept into something that could be implemented in practice?
Well, as I said, we have to apply the protocol to the preclinical scene first. This was a requirement of our ethics committee. And we want to show an increase in surrogate markers of perfusion as blood pressure, end-tidal CO2, and cerebral oxygenation. But after all, the really important thing for this patient is survival, and survival with good neurological outcome. So we will not get around doing a large outcome study, studying the effect on RIBOA on outcome, on survival and neurological function. And I think we will have to, we will have to compare it to standard of care, whatever this local standard of care is. In some countries, it might be eCPR. In other countries, it might be stay and play, like stay at the scene until ROSC or forget it. Whatever the local standard is, we will have to compare RIBOA to this. And further questions will arise from that. So
thank you. Bernd, did I see you had a question?
Yes, thank you very much, Gavin, and thanks Anja and Tino for this real, very interesting and new clinical research and field of research. I have two questions. First of all, how long does it take in under normal conditions in the hospital to put in such a RIBOA? So I have seen it before, but I never used it by myself. This is question number one. And question number two is, if you're doing it, if you want to do it in the future in the out-of-hospital setting, is that, if I remember right, you have physicians going in the out-of-hospital setting in Bern in Switzerland. It's not all over Switzerland, but maybe in many big cities. Is that correct?
Yes. We are concentrating on emergency, on our EMS, which is physician staffed at the moment. At the moment, we have even a second team that is well trained. It's only few people familiar with this procedure who will go out additionally to the normal team and perform RIBOA separately from the team performing ALS.
And the idea is the first team is there, they do 10 minutes of CPR, advanced life support, whatever it is. The second team, the trained physician is there, put in the catheter. We showed in clinic, in hospital, it takes about 9 minutes to put in the catheter. The ethics committee said we have to show it out of the hospital if the range is the same. And if this works, we are going to hopefully to a multi-center outcome study.
Thank you very much. And the ERC Research Net is a very good net for having a multi-center outcome study also on this kind of intervention, isn't it?
Yeah, we need money for this.
And participants.
Great. Well, I think you know, we've had some great questions on that topic. I'm just looking around the panel. Did anyone else have any questions, as we've not had any arrive in Slido? So, well, I guess it's to me to, you know, wish you luck, you know, and success with the next stage of the evaluation, as I think, you know, we need new novel approaches to improve outcomes from cardiac arrest, you know, whilst continuing to focus on optimizing those interventions that we know are safe and effective. We also need to, you know, advance the experimental treatment so that we really can move to a position of optimizing and improving outcomes for patients with cardiac arrest. I think we've reached the end of the planned presentations for this session, so I'm going to hand back to my co-chair, Bernd, at this point for further comments.
Yeah, thank you very much, Gavin, and cordial thanks to all presenters and to all participants in this session, and also to all participants in the ERC Research Net. I just would like to say some few words before I leave the stage to Gavin to let us have a view into the future and maybe a response on the results from the polls that you have performed during our session. So I just want to say I'm really very proud of the ERC Research Net, that this is really a unique research net. It's unique in the world. So cordial thanks to all participants from Europe and all around the world. This is about networking. It's about collaboration. We could have more money in the future from funding resources from the European Union and others. That would be at least a goal and a wish from my side. We have an ERC Research Net email list with more than 200 participants where we regularly send out newsletters and PDFs and requests for collaboration. So if someone wants to be on that list, just send me or Gavin or anyone else an email, and then we will put you on the list for newsletters, publication, information, and all this. And with this, I cordially thank all of you again for this great project, and will give the microphone to Gavin.
So thank you, Bernd, and thank you, for all of the effort that you have put into the ERC Research Net over the course of the last 8 years, because it really leaves the net in a strong position for me to take forward that vision and to work with the hundreds of members of the ERC Research Net in order to move forwards, building on the success of the last years. I'm going to show you the results of the poll. So thank you everybody who participated. We saw from the data on the Slido application that there were close to 500 people participating in this event, which is absolutely fantastic. And about 150 of those either contributed questions or responded to the various polls. So I think that in itself is a really good sign of engagement and the growing importance that research is becoming as part of the ERC strategy for improving survival from cardiac arrest. So I'm going to move through the slides from today. To remind you, the 3 questions were: how important is research to the ERC mission to preserve human life by making high quality resuscitation available to all? The second question: what would you like to see the ERC Research Net do more of? And then the final question: what would you like to see the Research Net do less of? So moving through the first of those, it's great news and something we must share with the board, a huge amount of support for the importance of the ERC Research Net and research for helping the ERC to achieve its mission, with 100% of people rating it as very important or important. Moving to the next slide, and this is a word cloud. So the larger the text appears, the more the number of people made the various comments, and so some of these are, I guess, maybe people repeating the comments of others. But I think the key things that have come out is very good as it is. Focus on education, children, human factors, advanced life support, randomized trials, online seminars, summaries of research, cardiac arrest projects, collaboration, financial support young children. In terms of things that people would like to see the ERC Research Net do less of, I think a sign of the resounding success of the network is that the majority of responders have said nothing, that they would like the ERC Research Net to continuing focusing on the areas that it's doing so at the moment. So I think that those provide some very useful insights into the views of the ERC Research Net, and will be, incredibly useful in terms of helping me form with you a strategy that will take us forward over the course of the next 5 years. I don't have any further comments to make at this point, so I'm going to hand back to my co-chair, Bernd Bottiger, for any closing remarks. Thank you, Bernd.
Maybe I suggest to start with, our further co-chair is resuscitating. Sorry, I forgot this. So thank you very much, Gavin, and thank you very much, everyone, again. It would be great, Gavin, if we can have these 3 slides of the results from that poll, and then I can send it out to all members of the ERC Research Net as some kind of a feedback. That would be great. And with this, I would like to repeat again, I'm very thankful, I'm very proud. I wish Gavin and all of us all the best for the future of the ERC Research Net, and I'm sure that we will be further successful. Thank you very much.
Thank you and goodbye, everyone.